Hi everyone. Welcome to this session on safer supply, lessons for policy and practice from Canada. My name is Magnus, and I work for an organization called CATIE, which is Canada's knowledge broker on HIV, hepatitis C, and related STBBIs. So our role in Canada is to try to support frontline organizations with evidence-based information and resources to support their frontline efforts. So this panel came about through a request from INHSU to have a dedicated space to discuss safer supply and learnings from Canada that attempts to build on other sessions, both at this conference and at previous conferences. So our goal for today is to take a bit of a step back and to try to tell the story of safer supply so far, and to share some lessons for other countries who may be developing or who may be considering developing safer supply programs or similar approaches. Before we begin, I'd just like to acknowledge that everything that we know about safer supply, from the approach itself to the research and the evidence that informs the approach, is thanks to the contributions of people who use drugs. So I'm going to start us off by giving a bit of a presentation to give some context on Canada's toxic drug supply and how safer supply emerged from this as a response that involves providing regulated pharmaceutical alternatives to the toxic drug supply. We'll then hear from our panelists about their perspectives on a number of topics, including the early implementation of safer supply, the current state of safer supply, some successes and challenges, and some lessons for other countries. We're also going to try to save a good amount of time at the end for Q&A, so please do take note of anything you've got questions or want to discuss as we go along. I'm pleased to be joined by a great panel of experts on safer supply today. So Juls Budau is a research advisor at the School of Population and Public Health at the University of British Columbia. Matthew Bonn is an advisor and a consultant to many efforts underway in Canada and is also an international board member of INHSU. Dr. Sara Davidson is the medical director of Riverstone Recovery Center, and Professor Thomas Kerr is the director of research at the British Columbia Center on Substance Use. On behalf of the panel, we have one disclosure. Sara Davidson is a co-owner of a social enterprise pharmacy where an injectable opioid agonist treatment that she does not prescribe for is filled, and has also done presentations on hepatitis C care for people who inject drugs, funded by both AbbVie and Gilead. So Canada has been in this crisis of toxic drug deaths for nearly a decade. Since 2016, over 47,000 people have died of opioid toxicity in Canada. And if we look at averages, since this conference started on Wednesday, another 60 people in Canada will have died of drug toxicity. To put this in context, there are more overdose deaths in Canada per year than in the entire European Union, despite Canada having less than 1/10 of the population. The core driver of this crisis has really been changes in Canada's unregulated drug supply that started about 10 years ago with the arrival of fentanyl. This chart shows the increased presence of fentanyl in provinces and territories across Canada. It also shows how fentanyl has been detected more and more over time, with this sustained spike that started during the pandemic, when Canada's closed borders and public health restrictions led to an increasingly toxic and really volatile drug supply. These deaths are happening across the country, but some provinces and territories are more affected than others. British Columbia, Alberta, and Ontario have all been particularly affected. On the panel today, we do have representatives from across the country, so we're hoping that you can get a bit of a glimpse of how the situation differs in different regions. It's hard to really describe the devastating impacts that this toxic drug supply has had, as it just keeps getting more and more toxic and more unpredictable over time. This slide just has a few snapshots of some news stories about this toxic drug crisis over recent years. There are a few specific trends that I think are important to be aware of for context about what we're going to discuss on the panel today. So while the toxicity and unpredictable potency of synthetic opioids like fentanyl and its analogs are really driving the majority of drug toxicity deaths, stimulants like cocaine and crystal meth are increasingly playing a role, and we've also had adulteration of synthetic opioids with sedatives like benzodiazepines and xylazine that have added this whole new layer of complication where people are unintentionally and unknowingly developing dependence on these sedatives and have also resulted in some really complicated overdoses. So this slide shows a chart of drugs that were found in samples that were expected to be fentanyl in Toronto. So as you can see, it's really just this highly unpredictable and volatile mess of mostly synthetic substances. I've also included a few photos here of fentanyl from an article that Matt wrote a few years ago, just to try to illustrate how much the drug supply has become this mixture of unknown chemicals. So responses to the harms of the unregulated drug supply have been scaled up in parts of the country, but these harm reduction measures are still fairly limited in scale and accessibility given the toxicity of the drug supply. We currently have more drug consumption rooms than any other country in the world, with over 30 officially sanctioned supervised consumption sites and a number of low-barrier overdose prevention sites in some communities. These have mostly been scaled up since around 2017, but as was noted earlier this morning and in other sessions, accessibility is low given the switch to smoking. There are also sites that provide drug checking in different parts of the country, both to monitor the contents of the local drug supply and also as a harm reduction service to give people more information about what's in their drugs. And healthcare providers no longer need special permissions to prescribe opioid agonist treatments with medications like methadone and buprenorphine. And naloxone has been made easily accessible to people, like the public across Canada. People can pick up naloxone for free at a lot of locations. And people who use drugs have really become experts in reviving their friends and family members across the country. Oh, can you go up? Thank you. So despite all these interventions being scaled up, drug toxicity deaths have continued to rise and to outpace our responses. So at the same time, the situation has become even more dire with, over the course of the pandemic, just reduced access to health and social services, reduced access to mental health supports, and increasing homelessness in cities across Canada. Each of these factors really challenge the ability of our responses to address the scale of this crisis. All this to say, it's within this emergency context that safer supply has come about as this additional option that can complement existing services and hopefully fill gaps within the range of harm reduction and treatment services. So there isn't a single definition of safer supply, but broadly speaking, it involves providing regulated pharmaceutical-grade alternatives to the toxic drug supply for people who are at high risk of drug toxicity or overdose death. It is primarily a harm reduction intervention, so while it builds on evidence from a number of treatment approaches, it's not necessarily intended as a treatment for opioid use disorder or for substance use disorder. Instead, its primary goal is to try to reduce the risk of death associated with accessing toxic drugs from the unregulated drug supply by providing people with a regulated alternative of known contents and potency. It is primarily delivered through a medical model, which means that people need to receive a prescription from a healthcare provider to access pharmaceutical opioids as an alternative to unregulated fentanyl. Immediate release hydromorphone tablets, or Dilaudid, are most commonly prescribed off-label as an alternative to fentanyl, and they are usually dispensed daily from clinics or pharmacies for people to consume when, where, and how they choose. Stimulants are much less commonly prescribed as safer supply, but there are some programs and prescribers, including Dr. Sara Davidson on our panel, who have experience providing drugs like methylphenidate and dextroamphetamine as alternatives to unregulated stimulants. These are just a few examples of concept, guidance, or policy documents that have informed the implementation of safer supply in Canada. And another important thing to note is that starting in 2019, there were a small handful of programs that started to receive funding from the federal government to run safer supply pilot projects. So this funding really allowed these programs to provide a range of wraparound services, including case management, primary care, system navigation, and other supports. But funding is running out for many of these programs this year, and the future of the approach is pretty uncertain in Canada at the moment. BC is the only province where we have data on the number of people accessing safer supply, or at least publicly available data. And this graph shows the number of people who received safer supply each month since March of 2020. If you look at the gray line on top, that is the total number of people who had access to any form of safer supply. The line peaks in February of 2023 at around 5,000 people in British Columbia that month, and it has been steadily decreasing ever since. This timeline of reducing access to safer supply really coincides with the rise of misinformation in media and in politics that has attempted to scapegoat harm reduction in general and safer supply in particular for a number of issues, from increasing homelessness and visible poverty that have been exacerbated by our housing crisis to being blamed for the overdose crisis itself. In this context, harm reduction interventions like NSPs and supervised consumption sites that have decades of strong evidence behind them are being attacked, and some of them are being closed down. So I'm grateful to have this panel with us here who are going to help us to tell this story and to share their perspectives on the lessons that we can learn from it. So we're going to start way back at the beginning and discuss the early implementation of safer supply. I'm going to hand it over to Matt. If you could please introduce yourself, and tell us a bit about the concept of safer supply and how people who use drugs have been involved in getting it off the ground.
Yes, thanks Magnus and Katie for putting this session on. I think it's extremely important. I think, hopefully the rest of the world will be able to learn some lessons from Canada on safe supply. When we think about the concept of safe supply, like where did it come from, right? And essentially it came from people who use drugs. So our National Drug User Organization, the Canadian Association of People Who Use Drugs, created a concept safer supply document. And I think if you look at all the peer-reviewed articles on safe supply, it'd be very hard to see one that doesn't cite that as kind of the first introduction of safe supply. So, this was very much brought on for and by the community. But, I think there were doctors kind of working towards providing safe supply at the same time, and it's evolved in kind of this beautiful thing where we had government funding for safe supply programs that have been operating. We are heading to dark times with this conservative government, but at least we were able to implement it, save a lot of lives, and evaluate it, and so we know what the evidence says. But I've also been involved in some of, our government does, they do an all right job at engaging people who use drugs on issues like this. So I sat on a couple of different councils, or advisory or expert advisory councils on safe supply. And, I think if we would have done this before the boom of fentanyl, it would have been a lot more effective. So, I think that's a key piece for anybody in this room thinking about doing it, because, fentanyl is here to stay. It may not be in your country yet, but, these things, the profitability and the accessibility and the easiness to just create some synthetic drugs, it's not going away. So if you can start to get people on safe supply before that hits your country, I think that's where it's going to be the most effective. And yeah, just a little, I've been on and off safe supply over the last couple of years. It didn't work particularly well for me, but I'm still here. I'm still alive, right? And that's less than I can say for a lot of people I know, right? And so, I feel very privileged and blessed. And, there's certain limitations that it didn't work for me, and I'll speak a little bit more about that later on when I share my lived experience perspective about that.
Thanks, Matt. So you mentioned that there were a few prescribers sort of prescribing a bit before COVID, but I was wondering, Thomas, could you please introduce yourself and also tell us a bit about the role that COVID played in facilitating implementation?
Yeah, sure. Thanks, Magnus. I'm Thomas Kerr, and I'm a professor in medicine at UBC and also a director of research at the British Columbia Centre on Substance Use, which was responsible for creating and implementing the risk mitigation guideline that kind of kick-started a lot of safe supply prescribing in the province. But really, it was motivated by what was happening in terms of the epidemiology of overdose. I don't want to bore people with too many numbers, but just using BC as a case example, in 2019, we actually saw a decline in overdoses in our province. We were still at around 30 per 100,000 persons. But by 2020, we had shot back up to 35. A year after that, 2021, we were at 45 per 100,000 person years. And with the number in the downtown east side neighborhood of Vancouver being about 12 times higher than that. It was pretty clear that, there was elements of the COVID experience and some of the related policies and practices that were intersecting and driving overdose risk. Obviously, people are being encouraged to isolate. But also, there were rules and surveillance practices that were put into housing environments that support people who use drugs that further encouraged isolation. It discouraged people from having partners and friends visit and use with them, and the result was that more people were using alone, and we know that in our province, the majority of people who die are using alone. There were also changes in supply. I think there's a lot of theories about that and how that happened. I don't know that anyone has the answer. One thing I certainly heard doing some qualitative work during the period was people kept saying, well, everyone's a chemist now. You know, they're trying to mix up their own dope at home. They don't know what they're doing. It's creating, you know, an unpredictable supply, et cetera. There are also very important service interruptions. For an example, in most supervised consumption environments, the number of seats available to people reduced. There were also a lot of rules that, when staff tried to enforce, created tension between people using the site and those staff. We've done some evaluation work, including work showing how workers in those environments actually resisted policy implementation from health authorities to better manage the challenges that COVID was presenting in their work. So given you know, this situation, the British Columbia Centre on Substance Use with the Ministry of Health and the Ministry of Mental Health and Addictions issued a document that's widely known as risk mitigation. And it was really designed to reduce overdose risk and support also many of the COVID policy goals. Trying to get people to make less frequent trips to the open drug scene to manage withdrawal and the risks that can come with that. And it offered prescribing guidance for opioids, stimulants, benzodiazepines, and alcohol management. Although particularly the updated guidance strongly recommends a combination of long-acting and short-acting opioids, there was a major focus on hydromorphone distribution, which had, you know, was a bit controversial given that this was a heavily fentanyl-exposed population. It was unclear what value that short-acting program would provide to people. We were able to look into some of our cohort studies, like the Vancouver Injection Drug User Study in Vancouver, to look at sort of the awareness and penetration of the risk mitigation guidelines. And we found that actually only 47% of our cohort had even heard of the risk mitigation guidelines. Among that 47%, only 66 tried to get access to prescription medication under the risk mitigation guidelines, and only 30% actually received those medications, which, you know, I think really points to an important thing in conversations about safe supply, especially when we hear political leaders say, you know, this is driving the epidemic and killing people. But I think, as Magnus has shown, very few people actually received safer supply under the risk mitigation guidance. And even now, with much lower, more evolved approaches offering a broader range of medications, you know, we're seeing very few people being retained in these programs, a lot of people coming in, dropping out, that sort of a thing. So lots to work to do, but clearly I think COVID was, you know, a major impetus for the development of this risk mitigation approach and early safe supply prescribing.
Thanks, Thomas. Juls, do you want to introduce yourself and just tell us a little bit about what it was like on the front lines when the risk mitigation guidance came in?
Sure. My name is Juls Budau. I have done my master's thesis research on prescribed stimulant safe supply, and I worked on the front lines of both the downtown east side and Prince George, 2016 to 2023. So I worked on the front lines in the downtown east side when the overdose crisis started. I was actually a family worker. I was hired to work with kids, organize Easter parties, and all we did was overdose response. Like, it was all hands on deck. Like, we couldn't drive mothers to their appointments because we had to have 3 staff in the 149 apartment building so that someone would be available to respond to overdoses at all times. So that was our entire job. And then I decided to move to Prince George, where my brother lived, to get away from the overdose crisis. I was also responding to overdoses in my building, on the street. I moved to Prince George based on 2017 stats. The overdose crisis just kind of followed me there. I responded to an overdose while playing Pokemon Go. And I ended up working in harm reduction again. I worked in a co-op building, and I was really scared when COVID happened and things shut down. But when the risk mitigation guidelines came out, it was actually really exciting. And like, I know that like the things that Thomas is saying are 100% true, like how effective is hydromorphone in the age of fentanyl, but I have seen a lot of successes. I guess it just looks like how you measure success. You know, for instance, I had like a friend and neighbor who, with a combination of methadone and is Dilaudid, would spend days not accessing the toxic drug supply, and then when something would trigger him, he would go out and use, but it wasn't like before where he was using every single day. So it's like he has time away. It's less chances of overdosing. He's spending way less of his money. I was working as a support worker through an overdose prevention site in Prince George, and had a client who was, like, his foot had been broken by the cops. He was having an allergic reaction to the metal they installed in his foot. He was kicked out of sober housing. He was in a scooter. He had an infected giant foot. And so I would, like once a week, I would spend a whole day with him, and I'd come find him, and the first thing we would do is we would go to the pharmacy, he would get his methadone, he would get his 14 Dilly 8s, he'd go to the OPS and smash them all, and then that would give us, like 4 hours that he didn't need to use. And so we were able to get him wound care, we were able to go look at houses, we were able to go return some recycling. So even if it's not like 100% like helping someone away from the toxic drug supply, I did see a lot of those successes. And I am someone who is actually now on prescribed safer supply. I feel really fortunate. In my city where I live now, Victoria, there was a program through an organization, AVI. They were losing so many of their staff to overdose death. So they implemented a program that's sort of like low support so they can have a lot of clients so that their staff would stop dying. And even though I don't work for them, I fit the profile, so they were able to kind of get me in. And so why it works for me is that I was able to have like a really early intervention. I didn't have to wait until I had a huge tolerance, which is so complicated to meet with with prescribed medication. And I was also able to do a benzo taper while I was just on OAT. The benzo part is really difficult when you're trying to do prescribed safe supply for both opioids and benzos. It's just really high doses that makes things really complicated for prescribers. I'm also lucky to have weekly dispense. I think if I had daily dispense, that would be a different story. And even though I'm like a stable person with a home, that would just be really difficult for me to juggle all of that. Is there anything I missed?
Oh, that's great. Thank you. Thanks, Juls. Sara, can you please introduce yourself and also tell us a bit about your work in New Brunswick?
Sure, thanks, Magnus. My name's Sara Davidson. I'm medical director, as you've heard, Riverstone Recovery Center. We're in New Brunswick, so I'm just going to situate that a little bit because I think everyone, BC has done such innovative work that that's usually what comes to mind when you think of Canada. But I could probably get to the UK quicker than I can get out to Vancouver from where I am. So Canada's pretty geographically huge, so just want to place that. We are in New Brunswick. It's one of the Atlantic provinces. So we're on the Atlantic Ocean rather than the Pacific Ocean. We're teeny tiny. We have a population of about 750,000 in the entire province. And I practice in the capital city, Fredericton, which has 60,000 people. So we're a glorified village that happens to be the capital, which gives us a cool art gallery and some good restaurants. But we're tiny. And how I got to the work that I do, running an injectable opioid agonist therapy clinic, is quite different in the story, so I'm just going to share some of that. I started doing opioid agonist therapy prescribing in about 2017, and I wanted to be really rapid access, so I just did it in a group room at the clinic that I work at. This was before Riverstone started. So for 2 hours on Tuesday, 2 hours on Friday, I would sit there with a nurse, and we would just do anyone that walked in off the street that wanted to get on methadone or Suboxone, buprenorphine, naloxone, they could just come in. And so we really began to get to know a lot of the people, and it was a safe space to hang out for a couple hours. So we'd have people coloring books, we'd have people snacking, people sleeping, people just talking, and all the people with uncontrolled ADHD circulating around the room really quickly so we could identify them all. And I just felt like I wanted to decentralize myself as the knowledge keeper and return that to the community that really knows what it's like to use drugs, to be in withdrawal, to struggle. So whenever we would get people, and just rapid access, like people could come in on Tuesday, they'd start on treatment, and then on Friday they could come back and bump their dose up. So it was kind of designed so they could just come twice a week and then get up to a good dose as fast as possible. They'd bring their friends, and we just would right away try to meet people where they were at. If anyone had questions about the program or what was happening or what they were experiencing, they would often, when they were new, sheepishly look to me as the doctor and ask me, and then I would just turn to the room and I'm like, let's ask the experts. And so just tried to really engender that. So what we started, I guess that made me privy to a lot of really intimate conversations between people with each other, so I could kind of be a fly on the wall, and also just people would begin to trust and share. So we noticed first, and sorry, one piece of context, we didn't have any heroin in New Brunswick. It was all diverted, prescribed hydromorph and hydromorph content for the most part, oxycodone as well, and benzos as well. So our needs weren't necessarily the same as in BC, and our overdose rate, thankfully, wasn't as high when this all started. But what I would start to see is crystal methamphetamine was coming in really heavy into New Brunswick, especially Fredericton, and the morbidity associated with that, just the suffering that people, a lot of the times because they were very vulnerably housed, and there's a lot of reasons to use meth when you're living outside. Keeps you warm, keeps you feeling safe, keeps you feeling loved, keeps you not feeling your hunger, and it's a very social tool with people that are living outside with each other. And so honestly, the start was, what can we do to help people? And the other thing is too, when they couldn't get their, because there was a big crackdown, as you know, on oxycodone, and it was harder to get prescribed meds sometimes to divert or to share or to do whatever you needed to stay out of withdrawal. So people were turning to meth because it would distract them enough. So we started to ask them, what would be the preference if, could we get you some medications that you could inject? Because that's the other context. New Brunswick has the second highest rate of intravenous drug use in Canada, behind BC, but no one ever thinks of us. And we don't have 30 years of infrastructure for people who use drugs. We have nothing. So I was like, okay, let's stop using meth if we can, because it's just a really, a lot of the people were using it and we're really suffering. And again, that's me paternalistic. I should let people use meth if they want, but I don't want them to be harmed by it. So let's let people use it recreationally, not as an ability to survive. And let's also see, can we help provide you with what you need to inject? So all of that led to, if we could become part of a program that would let people inject the opioids that they would like to have, they could use meth when they wanted to, not because they had to. And they would be able to inject something that would keep them safe, because we knew fentanyl was coming as a wave and we were trying to avoid it, like Matt said, get on it early. So we applied to Health Canada. We were one of 5 sites. There was 2 in BC, 2 in Ontario, and little old Fredericton that got 5 years of funding to run something. So that's fast forward to where we are now. And I guess that's a long story, but just wanted to give you the context. There's different reasons people come to this work. So I still do prescribing oral options. We also started to prescribe off-label ADHD medications 5 years ago for stimulant use. And that's led to us being part of a national trial, which I'll talk on a little bit later on in this panel.
All right, thank you all. So now we're going to move into sort of talking about people's perspectives on different aspects of the current state of safer supply. So I'll start with you, Thomas. For people who didn't catch your keynote, could you just tell us a bit about what the current evidence base looks like?
Yeah, sure. I summarized a lot of this the other day on Wednesday, but I'll try and provide a little more nuance in different areas. I think it's really important to separate the evidence specific to different models. And so, first starting with more of the RMG hydromorphone-based safer supply programming, I'll speak about that. And I certainly agree with Juls. While there's some issues for some people, there's a whole lot of benefit for other people, and the data really supports this. Initially, because of the limited number of people accessing safe supply, there was really just a whole bunch of good qualitative work done, a lot of it by my colleague Andrew Ivsons. And across programs, the findings were very, very consistent. People reporting a whole lot of health-related and social benefits, including reduced overdose risk, less reliance on the unregulated drug supply, and economic benefits, which is obviously understandable. But there was also, across studies, very consistent limitations noted. And these were really focused on the limited medication options, and also, just like what we've learned with opioid agonist therapy, a lot of the programmatic features of these services were also problematic for people, in particular the fact that these programs would operate during the daytime, and then they'd shut down, and then people would go use off the street at night. And also, you know, people would get frustrated with complex induction procedures and that sort of thing. We eventually started to see some good quantitative work, as I said the other day, first, you know, more out of Ontario, showing considerable reductions in healthcare utilization and healthcare costs, reduced both non-fatal and fatal overdose, including the large population-based study of BC's RMG approach. In terms of some of the, so switching to different newer models, which involve different medications, including various fentanyl products, we're kind of at a similar place. We're starting off, we have some very good qualitative evidence, getting into some of the nuance around it. For example, you know, our experience looking at people who really enjoy fentanyl patch. They don't have to go to the clinic every day. It's a slow, steady release. They like that. But we don't really have good quantitative evidence yet because a lot of these programs are small in scale, and we're just not there yet. Then the other model, of course, is the Compassion Club model I talked about the other day. We just have the one evaluation of DOLF, and while I reported the other day on our work showing reductions in fatal overdose among club members, I can also tell you that there are works that are in very mature stages of development showing things like quite significant reductions in interactions with police, reduced hospitalizations. And I think a really interesting aspect too is sort of the social aspects of the model and how much people prefer going and buying drugs from another drug user in a safe way that doesn't involve a healthcare system interaction. Massive. And it's my own view that I think this approach has real potential to be heavily scaled up. I was asked to talk a tiny bit about diversion. Obviously, it's a key concern. It's mostly focused on hydromorphone distribution, but there really is very limited evidence of harm, and that's been looked at a bunch of different ways, whether it's toxicology reports of people who are dying of drug poisoning in our province. Hydromorphone isn't a big thing. We're not seeing it drive new opioid use disorders in the province, and there is evidence of it meeting unmet needs. And I like what Allison said the other day. It's kind of like, you know, sharing the benefits. We've recently published a study that's just come out looking at the repurposing of hydromorphone and the unmet needs that people are experiencing. And people very consistently reported, you know, I don't always use it to, you know, replace the unregulated drug supply, but I use it to manage my anxiety, to improve my sleep, and very, very consistent reports around I keep it to manage instances of withdrawal and pain management. So again, I think you know, diversion remains a concern, but we really have to start thinking about it very differently and calm down a little bit, because the big harms people are talking about aren't showing up. Maybe there'll be a lag, we'll see. But right now, the diversion clearly looks like it's serving an unmet need.
Thanks, Thomas. Sara, could you tell us a bit about your clinical experience with Safe Supply or with IOT, and where these interventions fit within the spectrum of substance use services?
Sure, yeah. So I'd love to dive in a little bit more to explain some of the differences. One of the key things in Canada to keep note of is our healthcare is delivered provincially, so each province gets to decide what it's going to cover and not cover from what's reimbursed through income assistance, medication support. And I think that kind of is underneath some of the differences that you might see province to province. New Brunswick just happens to have liquid hydromorphone, 50 milligrams per milliliter, covered under our provincial formulary. Federally, for Indigenous people, it's also covered. So that gave us an opportunity when we were developing our program to not have to necessarily consider tablet safer supply. It did keep us in a very medicalized model, so I'll definitely own that. We've tried to make it, again, a super accessible same-day start. People can walk in off the street, people can self-refer. They just come on in, they do a small intake. If they don't have coverage for that medication, that's our first step, is to help them get coverage. We usually offer a bridge of methadone, which is a lot cheaper for them to just get a couple of days of not feeling sick. Some don't want that, of course, but some can, and then we can help them get coverage to then come onto our program. So they can come in, and then people can inject liquid hydromorphone. We do start at a certain dose. We titrate up. We've got rapid titration for people that have fentanyl, because we weren't able to avoid fentanyl altogether. It's certainly very present in New Brunswick now. But anyway, we try to get them biochemically kind of stabilized as quickly as possible. Basically, have them not feeling so sick, not feeling dope sick. And then they just come in, they do self-inject up to 3 times a day. We do span it out every 3 hours, like a 3-hour gap. And we offer a long-acting oral medication they can take overnight to stay out of withdrawal. I think about 75% of our peeps do that. We have between 60 and 80 people on our IOT program, so we're one of the biggest in terms of numbers of usage in some of the IOT settings in Canada, even though we're a tiny village. And I think in some settings it works relatively well because Fredericton is really small, so we're pretty accessible for people living in the area. We're not accessible to people all over the province, so there's ways I'm trying to think and talk and work with people to see about scaling up so that we're a little more available. Again, we land in the more medicalized model, but by having participants, we call them participants instead of patients, just to try to kind of stigmatize as best we can or elevate people's experience. We've involved them in the design of the program from the very start, and implementation and research we're doing. We pay people in focus groups in our program to come and share with us their insights. So we have really tried to co-create and grow and pivot. And as a not-for-profit, we're really able to do that a little more outside of the mainstream healthcare system, again, because of the Health Canada funding. So as part of that, I mean, this is really just the medication piece, but we do have wraparound. We have a nurse practitioner who's working on primary care with people. I do primary care. Everyone's terrified to go to the hospital, so we're doing workups all the time in the clinic. A lot of we avoided of sepsis, and our hospital team tell us they don't see nearly the amount of endocarditis and bloodborne infection rates. We've eradicated Hep C to below the WHO guidelines in our clinic alone for our cohort in our area, just because of access to people. So I think, again, it lands, I mean, I feel ultimately if we could legislate legalization and regulation of all substances, and then I wouldn't have to be treating people medically for people that don't really need treatment. They just need access to something that they can have safely, like the wine I had last night at a restaurant. I had Safe Supply last night. So I'd love to be able to provide that, but I guess I see, again, I'm a doctor, I'm biased, but I also see the role we try as best we can to be really engaged with people, listen to them and integrate and have them on staff. We have people that are now part of a low barrier employment program. So really the medication is the smallest piece. It's all the other stuff that wraps around people that I think is the true medicine that I can offer and our team offers. Our housing sucks in New Brunswick, so it's really hard to imagine that, I dream of a day actually trying to become special care home license holder to create spaces where people can live and use drugs in that setting. It's not flexible enough. We don't have the SROs that are out in BC for people to live somewhere where it's known that they're using drugs. Most people just get kicked out. So we still live in a very conservative province. We have an election in 10 days. Please send all of your love our way to kick out our current premier, and we'll have a much more liberal environment. But I guess I do see that there is sort of a role for people when they may self-define as having a disorder and want treatment, that I think there still can be ways to do it in as decolonized a space as possible. But I feel like at the end of the day, we do need to work towards a much more legislated and safer supply for everybody to then have a choice of treatment or just of living and using drugs because they want to.
Thanks, Sarah. Matt, just gonna go over to you and ask if you could share your perspective on safe supply from your lived experience with it.
Yeah, so, it's no secret to anyone here that I'm someone who uses drugs, and I've been on and off safe supply twice, but I think in the context of all that, I've tried methadone, I've tried Metadol, I've tried Sublocade, I've tried buprenorphine with naloxone, I've tried Cadian, I've tried every, agonist therapy possible. I started using drugs and, benzos, I have a lot of anxiety and, there's always an issue of being on methadone and getting a benzo prescription. So I think, when the first time I was on Safe Supply and, I have a lovely doctor, Dr. Leah Genge, who, would probably still take me on right now if I was struggling. You know, she offered me like 8 Dilaudid 8s and like a couple long-acting, slow-release hydromorphone carton to take on site so I wouldn't inject them, because there are a lot of people in Atlantic Canada that do inject the slow-releasing ones as well. And, you know, like it did me well for a while, but, you know, I had to go to the pharmacy every day. I remember it was right over Christmas break, Christmas time, and I had to go on Christmas Day to pick up my safe supply. And, you know, like I live a little bit more remote. Like I don't live right in the city, so it's like a 45-minute drive. And even if you do have a car, or if you don't have a car, like there's all these things you have to kind of think about, you know, like especially in the context of Atlantic Canada. You know, it'd be different if it was on the downtown east side and you were in a SRO, and, you know, you could have a pick of pharmacies within walking distance. But that just wasn't my experience. And then, you know, so I used to complain about that, you know, and instead of giving me carries, you know, my doctor, I think she motivational interviewed me and got me to got me to decide that I wanted to try Sublocade. And like I feel like I don't know why I ever listened to, like, she's just a sweet doctor. I don't know. You know, I guess I'm a sucker for a nice doctor. And I tried it for about 2 months, and it was like I either felt amazing or horrible. Like there was no in between. It hurt like a bitch. Like, oh my God, like like to get that in your stomach a couple times, like, oh my God. So I just stopped taking it, tried to go cold turkey, and this has kind of been like my patterns over the last couple of years. Then I start doing fentanyl again. And I remember, you know, it was, I remember calling them up and asking if I could go in the safe supply program, because we do have a safer supply program in Halifax. And it took like, they only see people on Wednesdays, that's it. And I missed the Wednesday, and they weren't going to be in for the next 2 Wednesdays. And I was like, I'm doing like 3 grams of fentanyl and 3 grams of cocaine a day, and you're telling me I got to do that for another couple weeks to see you? And I was so upset. But when I finally made it, I overdosed multiple times. I never died. You know, I had a great coworker who would always let me use at work, always respond to my overdose. She responded to an overdose once with no naloxone, and she had COVID, and she kept me alive for 16 minutes just with rescue breathing. And, you know, I'm very fortunate and very privileged to have all those, to have had those people in my life. But when I finally did get to see the doctor, she's like, there's no way you're doing 3 grams of fentanyl a day. I said, do you want to see? Like, look at my legs. Like, the track marks don't lie. Like, if you were to look at my leg, you would say, this guy has put a lot of fentanyl into his leg. And so she said, okay, I'm going to try you on a fentanyl patch. And I was like, thank God, because I knew hydromorphone wasn't going to just cut it. But then then she's like, well, what else are you doing? I was like, oh, I'm doing about 5 Xanax a day as well, and you know, I'm doing the cocaine. And she's like, well, we got to give you something for stimulants. We got to give you something for benzos. So the prescription I left with was 100 microgram fentanyl patch every 2nd day, 24 hydromorphone 8 milligram tablets a day, 120 milligrams of Ritalin a day to inject, and 3 milligrams of clonazepam a day to consume. And like, that's a lot of drugs. Like, that's every day. And my family just kind of was, you're just high. And I was like, well, I didn't overdose yet, so it's working. And they're like, yeah, but you're just high. And I said, well, that's the point. Like, I'm not, like, I'm trying to like just stay alive. And then I got a little bit greedy. I think I got a tax return or something, and I bought a whole bunch of cocaine and some street fentanyl, and I overdosed. And so I remember them like peeling the fentanyl patch off my arm, and I was just like, oh God, this is gonna be horrible. And that was the end of that. Like like I had no excuse to be on it with my family anymore. They're like, you just overdosed on your safe supply. And I was like, I didn't overdose on the safe supply, but I get what you're saying. Like, I get it. But, yeah, like, I couldn't get in touch with the safe supply doctors for a week. So I went cold turkey for a week. And then I finally got in touch with an old methadone doctor of mine who I think has been prescribing safe supply since, like, the 90s. That's just my theory. But he gave me methadone. He's given me methadone and benzos, methadone and Vyvanse, Metadol. So he does, like, I am on some type of safe supply, but I'm not on kind of your current safer alternative model. But I think the restrictions are just what messed me up. You know, having to go every day to the pharmacy, you know, not being able to smoke the fentanyl patch or inject the fentanyl patch. But like I said, I'm still alive today, and you know, I'm thankful for like that experience, and you know, I know it saves lives because I don't have too many friends left.
Thanks, Matt. I think that's a really good example of just like even though that program wasn't funded, just the flexibility within an individual prescriber. That's fantastic to hear about. So we're going to move into talking a bit more about some successes and challenges. We've talked about them already. You've heard quite a few, I think. But just to specifically touch on some new ones, or some ones that you've touched on before. But starting with Juls, are there any successes or challenges that you want to highlight?
I was reminded of an example. I think Sara was talking about people being afraid to go to the hospital. So in Prince George, I managed 2 different OPSs and hired all pure staff. And you could really tell who was like stable on safe supply or not, because they were the ones who were able to show up at work. And there was one woman who wanted to be stable on safe supply, but nobody does benzotapers in the north. You can't get them. And so she would have to continue buying off the street so that she wouldn't go into benzo withdrawal and have seizures and possibly die. So she would sell her safe supply, but she was selling it to, we had a new volunteer electrician who had recently relapsed. They were a heroin user in the 90s, and they were able to avoid using fentanyl because they were able to buy hydromorphone, and that was amazing. And then I remember one time, the woman, she had this horrible infection in her arm. I don't remember the details, but we were able to convince her to go to the hospital. And one of the reasons why she was able to go was because she had her safe supply with her. So she knew that she wasn't going to go into withdrawal when she was in the hospital. She was going to have at least something. And it wasn't something that they were going to take away from her, because it was prescribed medication in those little daily pouches. And she wasn't going to get in trouble for using that. So I think that those are some kind of like nuanced successes that we see. And like when Matt talks about all the barriers, like I feel so privileged for just like what I have. Like I do live in a city. It's, you know, it's a 5-minute bike ride to the pharmacy, or a 10-minute walk with my dog. I only have to go once a week, and that's really nice. But even getting there was difficult. I faced a lot of like stigma from the pharmacists when I first started there. I think they would call us, when I'd just be waiting for my prescription and looking at the makeup, they would call security. It was like, you know, because I was an outpatient, so obviously I stole a lot. I was forced to I was pressured to cold turkey benzos. maybe motivationally pressured after a doctor threatened to have my driver's license taken away. He said I was driving children around high on THC because I was, at the time I was nannying for a friend, and in my intake form I just mentioned that I often did a THC edible, usually when I worked at home before I wrote a lot of papers, not necessarily before I was driving kids around. So he threatened to have my license taken away, talked about the specific guidelines that clinic had about what would make them have someone's license taken away, and then he moved into the benzo piece and pressured me to cold turkey benzos when I was in that. If you're doing a micro-induction on Suboxone on the 4th day, you're kind of figuring out how much Suboxone you're going to take. And so it was during that time, I kind of didn't know I was like wired to benzos, so I was trying to treat the benzo withdrawal with Suboxone, and I was like up to 30 milligrams a day. And they were like, oh yeah, it seems really high, but everyone's different. And then a friend of mine, even like just from messaging like on Signal, a friend of mine was like, do you think maybe you're going through benzo withdrawal? And I was like, oh yeah, wait. So I actually only needed to take 18 milligrams of Suboxone, not 30. And then finally, they did give me a benzo taper. I think those are.
I think that adds a lot of nuance around like the successes that you mentioned, the sort of the frontline experience of people being able to go into hospital and feeling safe. That's important nuance, as well as like highlighting the stigma that you faced from the healthcare.
And managing 2 different OPSs, I saw with my own eyes a lot of diversion, but it was like mostly that. It was people who needed to sell because they needed to buy benzos. There were 2 people I knew very well, and I knew very well that they often did sex work to be able to afford their medications, and they both fucking hated doing sex work, these 2 women. And so, of course, they're going to be able to sell something that they have rather than doing something that they hate doing. Not everyone hates doing sex work, but these 2 women did, and they had a lot of trauma around it. And then the people who were buying it were people who were older, who had like decades of addiction. And I remember one man in his 60s was told at the hospital that he wouldn't survive another overdose, yet they wouldn't prescribe him safe supply. And at the time, the clinic, the needle exchange in Prince George, they have a cap of 150 people, and there's a really long wait list. So people are wanting to get on it, so they're able to buy it. So.
Thank you. Sara, just over to you if you have any successes and challenges that you want to highlight.
Sure, thank you. So I guess over the last 4 years, we've been, some of the successes I see, at least within our own microcosm. One is that we've found that people who many times have tried multiple times because they wanted to go on to oral therapies that didn't work out for them, and they continued to be at risk of the toxic drug crisis. Once they were on, we sort of joke that we bore them into going back onto OAT because they come 3 times a day and they get to know the staff, and they're sort of part of the program, and eventually they're like, okay, fine, I'm sick of it anyway. But we have had 19 people over 4 years who had never really been able to get onto OAT, get their feet under them in a way that met their need. And I'm not trying to sound like that is our goal, because it really isn't our goal. Our goal is to just meet people where they're at with whatever their goals are. And some people are working full time and injecting. They only come twice a day or 1 time a day, but that's all that they need to do now because they're sort of in a place that's what their bodies need and their souls need. So, but those people that have wanted to go over to oral therapy, they're very proud, and they come back and they speak with our other folks and try to encourage them. So that's one success. Another I'm pretty happy about is with the stimulant replacement therapy that we've done for a long time. We've showed up nationally. And so we are one of the sites for what's called the Ask Me trial, and it's intentionally called that because people with lived experience were involved in every step of this. So we're the biggest trial to date on the planet for stimulant replacement therapy. So we'll be publishing results probably in about 3 years, but we're in the middle of that now. So really excited about the Ask Me trial. And I think because we've had, we noticed people sticking around all day, just pride of place and feeling engaged, started to, if they saw cigarette butts in the parking lot, they'd pick them up and put them in the garbage, or they'd sweep, or they would do this or that. And we're like, why do we hire cleaners? Let's create our own cleaning crew. So people in the program, so we started a low barrier employment program, which is tiered to what people are able to adapt to. And one is just show up, and if there's jobs that day, whether it's painting a wall or whether it's helping be on a consultation process or help to create some kits, or whether it's to clean a shift, people just show up and they get paid at the end of it, and they can work overtime to engage more and more whenever they're ready. And we have one person who's gotten to the role of manager of people, and that's when she was still living in a tent, and she's now housed. So I think it's a lot of the wraparound stuff we get to do. We've had art projects that are was shown at our gallery in the city, and so that sort of stuff, humanizing people deeply. One of the things, though, for a challenge, Matt really elucidated it. I mean, just the different barriers to care. What I'm trying to do when I speak with anyone in Health Canada, we'll see when Polyev gets in and everything's a bit decimated for a few years, but in the meantime, my pitch that I'm trying to make from the medicalized model, at least, is we have what's called pharmacare coming into Canada slowly, where we're going to have nationally covered medications. And I'm trying to pitch that we could have different formulations covered through pharmacare, then we could bypass all those provincial barriers I talked about for what's covered. I would love to have powdered diacetylmorphine, powdered hydromorphone, powdered cocaine, powdered methamphetamine, and powdered fentanyl be available for clinical settings. Again, it's still medicalizing it, but it doesn't have to be that we can't have different approaches based on where people live and what they need. That way they could smoke, they could snort, they could insufflate, which is what they do in Basel, Switzerland, which is pretty cool. They could inject, they could drink their dose, just to meet people where they're at. Again, more in the medicalized end, but at least we could bypass a lot of the barriers. We could address that people who aren't injecting as much anymore and are now dying from smoking. We could provide spaces for people to have the dose they want and when they want and how they want, and we could maybe do that under federal guidance instead of waiting for the provinces. So I guess that's not a success yet. I hope I can talk about that as a success in a couple of years here, but that's the challenge, is meeting people where they're at in ways that, through all the different provincial barriers.
Makes sense. Thanks, Sarah. Thomas.
So I was asked to speak a little bit about the challenges related to evaluating and how that may pertain to the different models, and it's something I've talked a little bit about already today and also on Wednesday. But I think the key thing is that different models are presenting different challenges. If we looked at kind of the earlier models of hydromorphone distribution, I think those have been really well evaluated and shown some benefit, and obviously people are still doing that, and they'll dig down some more. But the priority there now is probably to look at the issue of deprescribing, because people are being just ruthlessly cut off their hydromorphone. There's, a lot of physicians are just hysterical about, hydromorphone diversion, and people are getting cut off, and I think it's something we need to urgently study. In terms of the kind of newer models looking at novel medication approaches, including the different fentanyl products, the challenges has been that these programs are so small. A lot of people come in, come out, some just quit, some go back to OAT. And so, I'm evaluating one of the 3-year Health Canada funded SAFER programs, and it's 3 years, and we still don't have enough data to be powered to do rigorous statistical analyses. I think related to those models, I think a challenge also going forward is we need to look at the implementation issues. We need to look at the programmatic barriers. I'm kind of surprised after all we've learned about how programmatic barriers in the context of conventional OAT limits access and retention that we have to go through this exercise again, that we actually have to talk about problems like closing your office at 6 o'clock and sending everyone to the street. But, I think those are the other issues. And then with the non-medical models, I guess my advice to you would be make sure you have a lawyer on hand. But, the one thing we did do that was smart is we got our ethics approval from 2 different ethics boards. So when the accusations came that, I had done unethical research, we felt well covered. But then there was also the allegation that I was, supporting a criminal activity. So, yeah, I did have to get a lawyer. But so far I've been okay. But we'll see where that goes. But again, I'm just such a big supporter of the exploration of non-medical models. I think it's an important step, and I think it's has the greatest potential kind of as a bit of a stopgap until we get to a truly regulated model. And so I hope that there'll be other examples of non-medical models that folks can evaluate.
Thank you. Matt, do you have anything you want to share here?
Yeah, you know, I think safe supply in the essence of it is a huge success, and you know, even though we are going to dark times in Canada, I think, you know, it's important that we did this while we had the chance to do it, and you know, we collected a lot of data, and you know, we saved a lot of lives. I think one success, and I'm thinking of the way to word it, but like you don't need a safe supply program to provide safe supply. You know, if you have a physician who is willing to prescribe it to you, you can do it with little to no restrictions. You know, you don't have to do urine drug screens all the time. You don't have to do daily pickups, you know. So I think it's about trying to find a physician that, you know, try the motivational interviewing on them, and you know, make it their decision. That's what I do with my doctor. I guess I learned that from the other doctor. But you know, like, yeah, like you don't need, you know, obviously these wraparound programs and very comprehensive safe supply programs are going to meet the needs of some of the more vulnerable people on safe supply, people experiencing homelessness or with a very unique drug dependency to xylazine or benzos or fentanyl. But, you know, I think building those relationships with doctors, getting them to prescribe you safe supply, I think that's a huge success, and that's, you know, even like that's what they're doing in Halifax now. They have a certain amount of clients. They'll say, even if Polyev comes in, I'm just going to take you to my family practice, and prescribe you safe supply. So I think that's a huge success. And the challenges, yeah, I just think, you know, I grew up on fentanyl. You know, I grew up on fentanyl patches and, you know, using hydromorphone. But I think, you know, the evolving and highly volatile drug supply is a huge challenge. You know, like we've talked about it, or, you know, like just listening to Juls with their experience in 2016, just responding to overdoses all day for work, and like, you know, I hope, you know, I'm optimistic. I'm a pretty optimistic guy, and I would like to think things are going to get better, but this is something that I'm having a hard time wrapping my head around.
Thank you all. So we have already heard quite a few of sort of important lessons to take away for other countries. But if you all just have one key lesson for another country who's looking to implement safer supply or a similar approach, whether that is something that a programmatic lesson, policy lesson, or political lesson, what would it be? Maybe starting with Juls.
There's a rhetoric in Canada that safe supply is palliative and it's sort of giving up on people. I just want to say 100% it is not. It is having hope in people, like giving them what they need, helping them stabilize. Being on safe supply has helped me so much. I wasn't able to bring it here to Greece, and that has been really challenging for my mental health. But you know, overall, like, my career right now is doing really great. I write papers, I make posters. I have an amazing boss, Dr. Amanda Slonwhite, in the audience. Thank you, Amanda, for all your support and patience. And just do it early. Don't wait. It's going to be much more complicated when you have to combine, you know, like methadone and hydromorphone and Valium. It's a lot.
Thomas?
So hard to think of one thing, but then I looked at all my list, and I realized that it can all kind of be captured by one activity, which is really talk to people who use drugs in your setting to find out what their desires and needs are, because we've seen so many examples in the research that's been done today where people are frustrated with things like not having the right medication options, the hours, the titration processes, etc. And I just think, I know there was an urgency in BC and other settings to do something quickly, and I agree, don't wait. But it doesn't take that long to really talk to people and figure out what's going on and asking them about what will work for them and what won't. We have to do a better job of attracting people and retaining them, providing them with a level of care that they're feeling good about.
Thank you. Matt?
Yeah, I think I have to echo what Thomas was going to say, or what Thomas said. I was going to say, just talk to people who use drugs, find out what drugs they are using, find out how they are using them, see if there's any kind of prescription alternative. Usually for an opioid there is, or for a synthetic benzo there is, and just start prescribing. Just do it, and you don't need a whole bunch of staff. Doctors get paid by their patients to so if you just prescribe it, and just prescribe it like any other medication. Like, it's crazy that if I was to go break my back, I could get 180 Dilaudid 8s once a month, but because I have an opioid use disorder, and that's on my chart or whatever, or I guess if I did break my back before I had an opioid use disorder, they would just give me my meds. I wouldn't have to do drug screening. I wouldn't have to go to the pharmacy every day. They wouldn't have to do pill counting. So I think it's so important just to prescribe it like any other medication. And I think we should seriously start looking at like cocaine compassion clubs and make them a thing for sure.
Thanks, Matt. Sara?
Yeah, thank you. Excellent. I echo everything everyone said for sure. So I think I'll just end on a really pragmatic note. You noticed the slide of my disclosures and probably thought, who's that sketchy doctor that owns a pharmacy? However, part of the reason that we started that was so that we could, so all of the billings, pharmacies make a lot of money off of OAT and IOT and SRT, stimulant replacement therapy. So what we did was we started one in a different city, St. John, where I'm not prescribing, but we have the pharmacy there. So all of the billings that we get through the federal coverage for Indigenous people and provincial coverage for people, we take that money, we reinvest it back in the clinic staff. And that's part of how we're going to exist even when Pierre Poilievre comes in, is by having self-generating social enterprise pharmacies. So if you have that ability within your country to start with that, keep all that money and then use it and give it back to the people that are in the program through helping have excellent staff. And if there's any left over, I don't think there'll be much left over because we'll be hiring peers, but use that money, recycle that money to be in as much control as you can as possible. So that would be my suggestion if you're starting out.
Thanks, Sara. And I'm just going to share another lesson that came from a panelist who couldn't be here today, and that's that we did quite a bit of knowledge exchange around safer supply to try to get service providers, pharmacists, nurses to help people understand what the approach was. But something that we may have missed was bringing the general public along with it, explaining to people what safer supply was, why it was being implemented, and what was happening with it. And I think that lack of communications and knowledge exchange to the general public allowed for this massive gap in information where it was able to be filled really quickly with misinformation by politicians and the media. There's tons of, you see it pretty frequently just thrown in that supervised consumption sites provide safer supply. And while that could be a great model, that isn't happening. That isn't very common at all. And so, just the need to bring people along to let people know what's happening and to just try to get in front of this misinformation that's really taken over in Canada. So I think, I've got a pitch before we go to Q&A. So we wanted to highlight some of this work that my organization has done about safer supply that is a bit of an evidence synthesis and has some evidence-informed sort of recommendations for service providers and for policy and practice. So the QR code takes you to this Katie statement on safer supply. But I also know that there are quite a few Canadians here today, so if anybody else has anything that they want to add, we do have about 10, 20, 15 minutes? 20 minutes? Anyway, we've got some time for Q&A. So I hope that if you've got questions, please, raise your hands or put them in the app.
I see a person.
Yeah, maybe Lynn? And then
Yeah,
there's a
come in.
microphone on its way.
Hi. Thanks. Amazing panel. Given the context and what we're facing in Europe right now, I feel like this room should be full, just in terms of listening to the expertise on safe supply that's being implemented. In Canada, I have a comment and a question. I suppose the comment on, the key takeaways, what should we do in Europe? So I'm from Canada, but I'm based in Europe now and have watched what's happening, back home. And the thing is that a lot of spaces in Europe, a lot of cities, a lot of countries, a lot of policy context, drug use is still only discussed with people who use drugs if they are discussing it in terms of stopping doing drugs. There's no conversations around doing it safer, that it's done for pleasure, that it's done for, that people use drugs. So that's an issue that I think in Canada there's a different context because there's decriminalization and there's this kind of language around that. So that's just one comment that I've observed from working over here. And then my question is, in terms of safe supply and how it connects to this conversation, at this conference yesterday there was a panel on decolonization of harm reduction. There's a concurrent session right now on Latin America and harm reduction lessons. How can we link conversations around safe supply to the supply end of people who are being affected by drug criminalization and things like this? And where does that come in? And I just want to know your opinions on that.
Can you simplify that question? Or say it again?
Supply. So from the produce end of drugs, so people in South America and the global South who are on the production end of drugs, and how drug policies and stuff are, and violence from the drug wars affecting them. How do you see it interacting with this idea of safe supply? And does that make sense?
I sort of see that, but also a lot of the drugs in British Columbia, especially, are produced domestically. There are who said everybody's a chemist? Was that you? Yeah, in the north, people are producing their own fentanyl, carfentanil mix. There are fake Dilaudids with nitazines in them, and that's a reason why I was able to get onto safe supply, because I was buying diverted hydromorphone, and just the risk of me doing one with nitazine and dying alone in my house, and that the lifeguard app sucks a lot. The timer turns off all the time, so I'd be dead in my house and my dog would eat me. And it wasn't worth me dying over that. So I'm not really. I don't know, does anyone?
Yeah, well, the one thing that sort of comes to my mind is that, if we accept that more medical-based models of safe supply aren't going to really give the kind of coverage that are truly needed, and non-medical models might do that, simultaneously address the fact that a lot of physicians say, we are overwhelmed, the healthcare system is overwhelmed, and we cannot take on providing safe supply to everybody, then looking to non-medical models like Dolph, what the two guys in the back of your shirt did,
One girl.
They acquired drugs from the dark web and then rigorously tested them and provided products that people preferred, including, among people who had prescribed safe supply. They were happier getting what they were getting from Eris and Jeremy. And, you know, it'll be really interesting because right now Dolph has a constitutional challenge. They applied for an exemption from Health Canada to legally provide drugs acquired off the dark web, and the answer was no, because you're getting it off the dark web. If you had a legitimate source, which by the way doesn't exist, then we would be fine with it. At least the court case, you know, it went really well. And Health Canada did not do too well, so it'll be interesting to see when that decision comes down any day now. So maybe in that realm, there might be some benefit for people on the supply end.
I have just a quick thought, acknowledging I'm absolutely not an expert in the kind of geopolitics and the deep issues that people in the global south face around just the way that a lot of the drug supply, which ends up getting exported, and does not go back to the people there, the benefit. If in a dream scenario we did get to a point of legalization and regulating, it might perhaps motivate organizations to produce the substances that are being distributed in the richer areas. So, I mean, that would be the dream, is could we actually could people who are in the industries already just continue to be in it, but perhaps providing a safe and legalized supply for other places or even for locally? But I wouldn't even want to begin to guess what would have to be done on the ground for them to do that safely in the different countries that are at high risk. But that would be my dream scenario. We would need to get it from somewhere, so it would be nice to try to harness who already is out there, the experts in production, to provide for especially richer countries if we're ready first, or whatever country's ready for legalized and regulated supply.
Yeah, and I think it's, I don't think every country needs to legalize cocaine, but I do think Colombia should. They would actually be able to make money off of their main export, and it wouldn't go into this underground criminalized world. And I think, that would help just to help kind of the world supply with cocaine, and help around like compassion clubs with it, and trying to eliminate some of these cartels, or at least I shouldn't have said that, but take that back. I think it's important to I could almost see like a social enterprise model. Like, selling drugs is a lot of work, so I'm not saying people shouldn't get paid for them, but they get paid ridiculous amounts of money. And I think if there's a way to split some of those profits and invest back into your community, I think you could be the best drug dealer ever.
I think I saw another question up front, just in the red, and then I see. Sorry, just the front first. Oh, are you going?
Here.
Yeah.
Hi, really, really illuminating panel. Thank you so much. My name is Sasha. I'm a doctoral student at the CUNY Graduate School of Public Health in New York City, but born and raised in Vancouver. So really happy to see this all here. This has kind of been touched on here and also in the keynote. It appears that harm reduction efforts like safe supply and safe consumption sites in Canada are are undergoing a PR crisis. I think someone mentioned that. And I'm just wondering what your thoughts are in light of this impending or potentially impending kind of conservative governance takeover in Canada. How do we bring the public along now that we're so far into the movement and there's this potential for the fracturing of the movement? And then what are the sort of like key messages and narratives we can use to get buy-in or understanding from those who are ideologically opposed?
Well, I think Sara did a brilliant thing and opened up a program that provides eye-out and safe supply and called it recovery. Certainly, that's the word in Canada now that's driving all the opposition to Canada to harm reduction and these kinds of initiatives. We, I've talked about this with a few people, but I really feel that in Canada, you know, there is a real right-wing backlash against harm reduction, and people who support harm reduction and work closely with people who use drugs are losing the communication war, and we're not organized. We do need to find narratives that matter. I think, you know, even physicians who have concerns about safe supply practice would agree with most other sensible people working in the area that it's not about harm reduction or recovery. We need a continuum of services, and there's excellent evidence to support that. You know, the work done in as early as, you know, the 90s showing that access to syringe exchange programs increase rates of admission to detox programs. That, you know, access to a supervised consumption site in Vancouver, there resulted in a 33% increase in the number of people entering first stage withdrawal management and then going on to abstinence-based treatment. So I think we need to point out that we don't need one thing, we kind of need it all. But right now, I'd say we're poorly organized against a very well-financed, slick communication machine. Yeah, we've really got to pull together. And at the same time, you know, I remember when Stephen Harper was elected and we thought the sky was going to fall. And yeah, it was very challenging in some areas. But at the end of the day, there was only so much that could happen. And, you know, that's why I find it really ironic now that Pierre Poilievre, the leader of the Conservative Party, is saying that he would, you know, close supervised consumption sites. Well, he was actually a member of the Harper government when they took it all the way to the Supreme Court of Canada and lost in shocking fashion a judgment 9-0 in favor of Insight's operation. So, you know, sometimes I think people talk a lot of shit during elections, you know? And then when the rubber hits the road, they have a lot of priorities, only so much they can do, and people get a tiny bit more sensible. But again, I think, for me anyways, a big message is to, you know, talk about how we need it all. And, you know, a system that consists only of harm reduction or only of abstinence-based programs is not the best system.
And I also want to point out that this backlash kind of happened like in response to a lot more people understanding like consumption sites and safe supply. Like when I opened my first OPS in Prince George, which is a very conservative area, just made these really cute TikToks and like posted them around, and then like, you know, old ladies would come by and drop off socks, and it was like kind of like a community space, just things like that. And then I just also, so when I was working in the downtown east side, Gabor Mate was the doctor of one of my clients that was prescribing her hydromorphone, and I'm going to say that publicly. Gabor, write a book about this, call it Trauma Informed. Please, we need you.
Yeah, and I think it's important, language is important, right? And I think, like Thomas said, what Sara has done has been beautiful. Even though I hate like the word recovery, you know, I think it really depends on the context. And I think, you know, the opposition to harm reduction and supervised consumption sites, like they're starting to co-opt our language, and I think we just got to co-opt their language and fight them tooth to tooth. And, you know, just it's going to take a lot of writing, a lot of advocacy, but I agree with Thomas as well. Like, I don't think it's going to be as bad as what we are making it seem it's going to be, but I feel like we do got to be well prepared.
I'll just add at the end that I think it's also important to remember that we're coming still out of the tail end of the pandemic, which really made a lot of people incredibly insecure and really want to grab onto something certain. And politicians jump all over certainty. So I think that's happening. There's also just, you know, pendulums always swing. You've probably noticed that. So we really did get really far, and now there's sort of a necessary, maybe it's not really necessary, just physics makes it necessary, kind of goes back and forth. Yeah, Poilievre wants to get elected. He's grabbed onto a few things that really are hot button things people don't understand as well. I know locally in Fredericton, we've also faced a bunch of backlash, but the way that we've really worked with that is every Friday we have something called Snacktivist. We've had to close it down for a few months because we're renovating our space, but we get stakeholders like the mayor, the chief of police, local city councilors, et cetera, to come for a tour over lunch when we're closed. And they get to see the space, to actually see what it is. And then at 1 o'clock, when people come back to get their first set of shots in the afternoon, we have snacks, and they come and they sit and they hang out with whoever our guest is and engage in conversation. So it's really humanizing and destigmatizing people. And it's kind of neat because the mayor left like, oh my God, like the stories I heard and the people I met, and I never would have thought. So it's that kind of getting to know people. But then the people in the program went, you know, I think the mayor actually gives a shit about me. And so it was sort of worked both ways. But it's really about building collaboration, and really, I think at the end of the day, people love stories. As much as we're afraid, people need to be reassured. And a lot of the ways comes through really humanizing people. So it does come down to messaging, and there's going to be different approaches different people need, from evidence messaging through to humanizing stories.
I think I saw, another question up at the top.
Thank you all for such a great panel. I'm Rachel from the University of Kentucky in the United States. And my question is kind of about, you know, we're living in this volatile, rapidly changing, toxic drug supply. And so how does the medical model, safer supply, become more in real time, like responding to a rapidly changing supply, rather than, you know, waiting, because even though fentanyl may not be in some places, you know, it's here. And so how do we like get ahead of what's coming next? And my second question is, are there any models where a medical model partners with a non-medical model, you know, a compassion club, to really make sure that you know, consumer preference and choice is like that availability, and kind of this partnership working together to make sure that what people are wanting, that's met and available?
So 2 questions. Maybe one person can respond to each.
Sure. So in terms of how we scale up fast, that's a great question. I guess part of what could be done is to not necessarily expect that we're going to suddenly have hundreds of nurse practitioners and physicians comfortable with prescribing in this way. So to set up hubs and spokes is what I'm trying to advocate for, in the East Coast at least, where find your local champions, because there probably are a couple crazy doctors and nurse practitioners out there. So find them, see if they'd be willing to mentor other people. And again, the payment model and all that might become a barrier, so you have to sort of find a way that you can support that person to do it. But if they can become a local expert, the pandemic, one good thing was virtual care has become ubiquitous now. So if they could actually be the sort of hub that supports the spokes to start prescribing in that way, you might be able to scale up a lot more rapidly. The clinic, Riverstone Recovery Center, I go there for an hour in the morning and we review everybody, and the rest of the day our licensed practical nurses, which are community college trained, run the show. Because I'm very comfortable, I'm not risk averse, and I think they do an awesome job and they're well trained. So we actually have them providing all of the care through a lot of kind of order sets and that sort of thing. So I oversee everything, but I'm not actually there all day long. So you don't need a bunch of doctors, you just need a well-run, efficient system. And we work with not-for-profits in Moncton and St. John, the 2 southern cities in New Brunswick where we're opening IOTs. They're alongside not-for-profits. One is alongside a safe consumption site, and the nurse practitioner that works there is going to prescribe for that IOT, and the other is along with a Hep C not-for-profit organization. So that's not a compassion club, it's different, and I won't be able to speak to that as much as these other folks, I would say, but I think there's ways we can model healthcare better across the board, and this is one way through hub and spoke of mentoring. So find the cool people, get them connected to other slightly cool people, and then bring them along, and get your nursing staff to really help deliver the care. Not ones you have to import from other countries that are really, you know, I mean, a lot of places are coming and we're sort of draining from other countries. You can work with the lowest, like the fastest trained people, but push them to the peak of scope, support them really well. We have a bunch of our personal support workers in our clinic that are now becoming LPNs, and our LPNs becoming RNs, and our RN became an NP. And so it's really helping elevate people, and then you train a bunch of people in cool harm reduction concepts. So yeah, look at systems change, look at how to deliver virtually, and scale up to peak of scope anyone that you can get to work in your spaces. And I'll leave everyone else to comment on collaboration.
I could comment on. I could comment a little bit on the first one. I had to step away from frontline work, and I work in research now, and it can be excruciatingly slow, but you know, we do our best. And so one thing is how the toxic drug supply, it's really affecting people who are incarcerated. When they are incarcerated and they're cut off, and like benzo withdrawal is a huge issue where we live. About, you know, almost half of the down supply, which is what we call fentanyl, what used to be heroin, it has benzos in it. So a lot of people are physically dependent on benzos. And so we've just submitted a grant proposal, hopefully, to there. So there's benzo withdrawal happening in prisons across the province, but there are prescribers in a few of the pre-trials who are providing benzo tapers. So we're hoping to go in and interview those people who have experienced it. What did they good? What could we do better? And then we're using a learning systems model. So as we get that information from the inmates about the medical care that they got, we're able to disperse that information to the medical staff in the prisons throughout the province. And hopefully CHIR is watching this and they give us the money.
We're out of time, but Thomas, do you want to just 30 seconds on the
Yeah,
combination?
sure. I mean, I don't know that there is a lot of opportunity for, you know, people to support non-medical models this time, but, you know, an important part of the Dolph story that people don't often hear about is actually, you know, one of the city's medical health officers gave them a space that was owned by Vancouver Coastal Health under the provincial emergency public health emergency orders, gave them an exemption to do drug checking and an exemption to run an OPS, and also gave them $200,000. And that was actually, you know, half of the outrage and controversy that happened after they were raided. Oh gosh, you know, they weren't just selling drugs, but they're getting all this money from the health authority, and the BC Centre on Substance Use is doing their research and this kind of a thing. So, you know, I think we have to find ways to support these initiatives. It does come with some risk for everybody who does get involved. Yeah, I think it's a tough one. I hope we can get there.
I think that's all we have got time for. So can you please join me in thanking our panel today?